Thanks, Rachel. Thanks very much for inviting me to the session today. So if you don't know me, my name's Paul Seamer. I work in the strategy unit. I'm an analyst there. And so probably should start with an outline of the plan for the session. So I'm going to talk about work we've been doing in a strategy unit around this question of modelling the impact of population ageing on demand for healthcare. I'm going to share some information about key concepts and sort of how we've approached this work. And then kind of in the second half of the session, I'm going to walk you through a beta version of a web application or interactive tool that we've developed that allows users to explore how demographic change might affect demand in their local area under different scenarios. And I guess this idea that the primary output of our work is going to be a web-based tool is a fairly novel departure, at least it is for us, from kind of more traditional written reports. I know it's something that other analysts have tried or are keen to experiment with. So kind of super interested to hear any reflections people might have on kind of using these kind of or kind of experimenting with these more interactive outputs rather than traditional reports. And then finally, a little bit of a plea or a request for help. So I'd like to ask you to consider volunteering to help me with some user testing of the tool. So we have an early version with all the main features complete that I'll kind of demo and share with you in a bit. But before we move to kind of a wider release and make it accessible to the public, I'd like to do some user testing. And how I envisage that working is that if you volunteered to help me with that, I would send you a link to the tool. You'd spend a little bit of time trying to break it, essentially, and providing some feedback on what works well, what works less well, anything that's missing, things you don't understand, maybe ideas for future developments. And then I'd review that information, make any changes. For example, if multiple people kind of all kind of suggested the same thing, then obviously we try and incorporate that. Or we might use the suggestions as a means of prioritizing future developments. So can I ask you please to have a think about whether that's something you'd like to do. And I don't think the ask is huge. I'm kind of envisaging that perhaps you spend 45 minutes, an hour tops, looking at the tool and just kind of jotting down a few kind of initial responses, thoughts, ideas, and literally kind of bullet points is more than enough, and just to kind of then send them back to me. So at some point I'll drop my email into the chat, and if as we go through you think that's something you're able to help with, then just drop me an email and I'll arrange for you to be sent a link to a version of the tool and kind of give you kind of all the instructions or guidance that you need. So thank you. Can I just check everyone can see my slides? Can I have a thumbs up? Yes, okay, great. Oh, lots of thumbs up, brilliant. So this kind of question of how much healthcare our population will need in 5, 10, 20 years time is a recurring theme in many of the projects that we get involved with. It's what I think of as one of those big questions in healthcare that people keep coming back to, and that's because it's kind of absolutely fundamental as an early step in any decisions on scaling and designing health services. But it's also a difficult question. By definition, the future is uncertain. So the quote, I think, the quote is, prediction is very difficult, especially if it's about the future, something like that. But we need answers. We can't plan and build, for example, 40 new hospitals without making some judgments about how population size, age structure, and health status might change. So kind of the need for healthcare is largely determined by the size and age sex structure of your population. And those two channels are two channels that are often represented in population pyramids. So we've kind of got some rather funky 3D printed ones here from a French designer of different countries in the world. And those two channels are kind of fairly straightforward. Other things being equal, a bigger population or an older population will require more healthcare. That's fairly straightforward, I think. And so a perfectly reasonable starting point for modeling exercise is to take current patterns of healthcare use, combine them with expected changes in population size and age structure, and use that to derive an estimate of future demand or need. And I'd say that that's kind of relatively easy to do from a modeling perspective, and that's because those two channels are kind of neat, tractable concepts, and we understand them quite well. We have access to good data. There are established methods for incorporating those in models, and there's a reasonable degree of consensus on how those two things might evolve in the future. We're not completely certain, but to a degree, the shape of the population in 10 years' time is somewhat determined by its shape now. But those aren't the only two channels or concepts that we might want to consider. There's a third, and this third channel, which I want to move on to talk about, is health status. So age is not the sole cause of healthcare use. In the short term, age might be a reasonable kind of proxy indicator for health status, but over the long term, those two things can diverge. So it's possible for a population to both age and become healthier. So in that scenario, then what we're talking about is that future gains in life expectancy would be spent in good health. And if you follow kind of the stories that constantly appear in the popular press, then it's kind of headlines like could 60 really become the new 50, like those sorts of headlines. But conversely, we might age, or our population might age and become less healthy. So average lifespan might improve, but the prevalence of chronic diseases and disability might also increase. And 60 might become the new 70. The premise behind these headlines is that the health status for someone of the same chronological age might shift over time. So health status is really important, but it's often overlooked in modelling exercises. And I'd argue there's a good reason why it's overlooked, and that's plainly because it's quite difficult. It's a fairly, or at least if we compare it to population size and age structure, it's a much more abstract concept. It's multi-dimensional. There are lots of different measures. Are we talking about disease-specific measures, or are we talking about more general measures of health? Are we talking about self-reported measures or measures from administrative data sets? It's difficult to track over time. Definitions are kind of constantly changing. We don't have access to kind of good long-term data in this area. The methods to incorporate health status in modeling exercises are kind of much more novel, they're less established, and importantly, there's much less of a settled consensus or certainty about how status might change in the future. Kind of people have lots of different ideas, very different ideas about how it might evolve. And that creates a challenge for us as analysts, I think. I've tried to kind of boil it down to three questions. The first being, given that kind of lack of consensus, how do you reach a judgment about how population health status might evolve? And this is kind of a question of how are you going to calibrate your model when the evidence that we do have is so limited and contested. And then a second one, kind of an issue around reflecting uncertainty in modeling. So I think that's a general issue for all models that we need to be aware of and take account of, but it's kind of heightened here because of that contested nature of the evidence base. So in these situations, a single estimate is probably not going to be of much value. And so you need to think about how you're going to incorporate and reflect and communicate that uncertainty with the users of the model. And even if you've managed to answer both of those first two questions, then there's kind of a technical challenge about how you incorporate a measure of health status in your model, about how you operationalize it within the model when we don't kind of have established methods to rely on. So if we think about how we might answer that first question about reaching a judgment on how healthy a population might be in the future, then there are two kind of opposing scenarios and a whole range of possible outcomes somewhere in between. And they're kind of classically referred to as expansion of morbidity and compression of morbidity. So in the future, for example, kind of in the diagrams that we've got here in 2035, we're assuming that on average, people in our population will live longer, but the period or time or proportion of their life they spend living with ill health or disability might change. It might expand such that average health status for someone of the same age in the future worsens, or it might be compressed in kind of a more optimistic scenario, and there the average health status of someone, you know, of a 75-year-old in the future is actually better than that of a 75-year-old today. And clearly there's kind of a whole range of possible outcomes in between those two kind of scenarios at kind of the opposite ends of the spectrum. But which is most likely? Well, unfortunately, the evidence that we have is rather limited. But you know, we still need to, in order to build these models, we still need to be able to somehow reach a judgment. And one of the things that, or one of the options open to us as analysts, I guess, in these situations is to fall back on expert opinion. And you know, that's legitimate in some situations, I'd argue. So in, I think it was autumn of 2022, we were involved with an exercise where a group of independent experts were corralled to form a group and asked about their views on how population health status might evolve in our country, in England, over the next kind of 15, 20 years. And uh, uh, the exercise was ran by someone from the University of Sheffield, so they kind of followed a set kind of established academic method for eliciting views from this group of experts. And a particular question or quantity of interest that they were asked about was the one you can see here about the proportion of remaining life expectancy that might be spent free of disability. So they were given access to a range of kind of supporting materials which showed things or gave them information about how this particular metric had evolved in the past. So you can see kind of 5 data points up to 2019, where it's kind of hovering around 50%. And they were asked for their view on where that metric might be in 2035. And so on the right hand side of that slide, you can see the results from that exercise. And so broadly, their consensus, the consensus of the expert panel, was that the share of remaining life spent free of disability or a long-standing illness at age 65 would fall slightly by 2035. So from almost 50% down to just below 47%. But one of the nice kind of properties about these exercises is that you can use it to capture 3 things. So you can use it to capture their central or most likely view. You can use it to capture the degree of uncertainty around this central view, which is kind of my rather poorly drawn kind of freehand black line around the 46.8%. And you can use it to extract the balance of risk. So here we're asking kind of, is it considered more or less likely that the actual value will be higher or lower than the central value? So you don't have to have a distribution that's kind of normal shaped. You can have a skewed distribution. So you can see here that although their most likely view was the 46.8% figure, they also thought on balance it was more likely that it might be higher than the 46.8% than it would be lower than the 46.8%. But you can see, there's considerable degree of uncertainty around that kind of most likely value. And that distribution that I've kind of just shown you is a key input to our model. And essentially, we use that information to adjust individuals' chronological age to estimate their health status age. And then we also sampled from that distribution in a Monte Carlo type process to generate lots of potential futures. So that distribution was kind of really key to inform our treatment of health status within the model. So having kind of talked a bit about kind of some of the concepts that underpin the modeling itself, I'm going to kind of move on to talk a bit about kind of our primary output, which is kind of this interactive web-based tool. And thinking about the reasons we chose to develop that, then we're kind of trying to achieve a number of things. One, we think that with these different sorts of outputs, potentially we can engage a much wider audience. That's the hope. We want to raise awareness of kind of this often overlooked issue around the treatment of population health status. within these sorts of models. I don't know. I don't know if I've used this phrase democratize, which kind of sounds a bit. I don't know. I'm not sure whether I like it, but we want to share and make widely available our approach such that it can be iterated on and it can be improved and compared to other approaches. And we want to kind of do better than we have in the past in terms of particularly for these kind of big questions where we're looking, into the longer term about how we communicate in a useful way some of the uncertainty around our estimates, and that's kind of inherent in these models. So kind of those are kind of the broad objectives that we're kind of trying to or hoping to achieve with the particular output. So unless anyone kind of wants to kind of has a burning question that they kind of want to ask me now before we move on, I kind of the next part of the session, I'll kind of stop sharing these slides and give you kind of a demo of the tool itself. That's okay. Okay. Let me just show a different window. So can everyone see my web browser now?
Yep.
Yep. Okay, great. Okay, so this interactive tool then, the structure is a single page. So you scroll up and down the page. There's kind of some narrative text which kind of helps describe what you're seeing and helps orientate yourself and explain a little bit about the model. And then we've kind of got three interactive, that's the first one, two, three interactive visual elements that work independently and allow you to select data specific to your local area. There are also some links out to further information, and you can download the underlying data as well if you want to. So the tool itself was built with D3. So if you haven't heard of D3, it's a JavaScript library for it's designed specifically for generating these sort of interactive visualizations in web browsers. So I'll kind of talk you through each of the three interactive visual elements in turn. So the first one that you come to is kind of the first thing that we were discussing in those slides is around how population size and age sex structure might change in your local area in the future. And we've kind of got this interactive population pyramid. So when you land on the home page, it will default to showing you data for England, but I'll show you how you change that in a moment. So we have a population pyramid here showing us the situation in 2022. If we click on this button here, it will play through and show us how our population is expected to change in the future all the way up to 2043. So this is for England. You can kind of stop it at any point, and you can also, if you're too impatient to wait for it to move through, cycle through, you can drag it up and down as well. And over here, we've got the ability to select data specific to your area. So we've got every upper tier and lower tier local authority and or 40 odd, 42 ICBs as well, ICSs. So, I don't know, if you're in Barnet or Barking and Dagenham, particularly young population, you can see what it looks like for your area. Again, you can play that through. The other thing you can do is if you want to lock the age structure and get this black outline in a particular year, you can then play it through and kind of get a neat comparison of the point at which you fixed it, which was 2022, and the point at which you stopped it, which here is 2041. Turn that back off. Let's select. So Barking and Dagenham was a young population. Let's select, I don't know, somewhere like Worcestershire, which will have a very different shape, I guess, and a much more top-heavy, an older population. And the other thing you can do here is, so at the moment this is defaulting to showing us ONS's principal projection, but the Office for National Statistics also publish a number of variant projections which kind of take into account different assumptions about fertility, mortality, and migration. So we think they're going to be different than the principal. We can select high life expectancy, low life expectancy, different ones around different assumptions around migration, and fertility levels and mortality levels. So I think there's 11 different variant projections there. So you can kind of play around to your heart's content about how your population size and age structure might change. So that's the kind of the first interactive. Yeah, sorry, Rachel.
Sorry to interrupt. I wasn't sure whether you could see my hand, so I thought I'd put my hand up and shout.
Yeah.
I was about to start doing this as well. No, it's just a comment in the wasn't really. There's a comment in the chat from Colette. So Colette is asking, are you looking at ethnicity as well as age? B&D is an outer London borough with a very different, diverse ethnic population. So what else is included?
Yeah, so ethnicity is not shown in here. I mean, perhaps I'll go through and I'll come back to that, because it's a question that people do ask. But this is essentially kind of a traditional population pyramid, which is showing age and sex structure, and obviously kind of particular London boroughs will have very diverse populations, which might show up as a more typically as a younger population, but we're not kind of showing explicitly the ethnicity breakdown. So the second visual element is around the relationship between age and use of healthcare. So we kind of have these activity profiles. So for certain types of health service, they'll have very different age profiles. So you can kind of see here, we've got a breakdown for ambulance arrivals and walk-in arrivals to A&E departments. Again, this is defaulting to the position for England, but I'll change that in a moment. And you can see that the relationship between age and the use of those two modes of arriving in A&E is very different. At the moment, the tool is focused on the three main acute points of delivery, so A&E, inpatients, and outpatients. So if we switch to inpatients, we have things like unplanned admissions, elective admissions, and also bed days as well, the different profiles there. And if we switch to outpatients, then we have procedures and first and follow-ups split by surgical and non-surgical specialties. And again, we can let's pick somewhere. Let's pick Birmingham then. And it will pull through data specific to your area or the area you select. When those areas become smaller in terms of the population numbers, these profiles become kind of more volatile or more uncertain. So you can you click here, you can kind of smooth those relationships, because for some of the smaller areas, it becomes a bit difficult to see exactly what's going on. And again, the same with the population pyramid. There's a button which you can click on to download the underlying data. And then the final element, it kind of shares the results of combining those the first two things we've seen. So information on how we think your population size and age structure might change, what we know about the relationship today between age and healthcare use for those services in your area, and our assumptions around how health status might change based on kind of the views of that expert panel, which I discussed. So you've kind of got a couple more of extra boxes here. So again, you can pick your area. Here you also need to choose the model horizon. So it's in kind of 5-year bands out to 2040. And so you'll get different results if you change the model horizon. Again, you've kind of got the same option to pick the point of delivery you're interested in. Is it inpatients, outpatients, or A&E? And I'll come to that last one in a minute. So what you're seeing here is a modeled estimate of how demand or need for that particular service will change over the horizon you've selected. And the darker, more purple bars are kind of what we think of as more likely, and the yellow bars as less likely. So, for example, for unplanned admissions for England by 2040, the model's expecting or estimating an increase of, somewhere between 20 and 22%. That's kind of its most likely view, but it could be, depending on how health status actually evolves, and we're not certain about that, it could be as low as 12%, or it could be above 25%. And that's with the ONS's principal variant, or their principal variant for from the population projections that they publish, the subnational population projections. But you could change that to select one of the variant projections, and if you do that, then you're going to get a slightly different set of results. So if you have reason to think that perhaps one of these variants is more likely than the principal, then you can see what effect that might have. I'm sorry, someone's just asking a question. What's that question? Yeah, okay, so someone's asked for a translation for the Latin. Yeah, I wouldn't worry about that. That's just a placeholder for things I've yet to add.
Well spotted.
Very good.
Yeah, good attention to detail, Ivan. Well done.
Oh, sorry, I completely lost track where I was. So, so the other thing that you can see here is so this range of possible outcomes is the result of kind of the Monte Carlo simulation. If you wanted to know let's completely ignore health status as part of the model, and just tell me what the change is going to be based on changes in population size and age structure, then you can click here, and a red dot will give you that answer. So that's kind of the kind of brief kind of tour, if you like, of the tool and what it can do. Kind of as you kind of helpfully pointed out, there are a few things that we need to add to finish it off. One of them being kind of the missing text at the bottom. but kind of going back to the user testing, kind of the, hopefully now you've kind of seen this, you've got a kind of a bit more of an idea of what that might involve. But essentially, it would involve kind of messing around with this, reading the narrative, telling me whether it makes sense, seeing if kind of selecting particular combinations of these might somehow break the tool. Hopefully it won't, but that's kind of what we want to test before we release it to the wider public. Kind of any other feedback, that I kind of feedback about kind of, well, what about ethnicity? What about deprivation? If kind of those are the things that kind of immediately kind of at the forefront of your mind, kind of when you're going through, kind of be helpful. Even if I can't address them within the tool itself, to kind of have some kind of stock questions that maybe we could treat as a link out to FAQs or something for other people that kind of have the same thoughts when they interact with it. So I'm going to stop talking now, and we'll see if we get any more questions. I'm just going to pop my email address in the chat so people can contact me if they're interested in helping me out with the user testing.
So yeah, thanks very much for that, Paul. So I'm aware that not everybody can see the chat. About half the people can't. Still worth putting it in there. I'll share your details afterwards as well. And so people, because I know lots of people put the thumbs up to say that they wanted to sort of help you. We do want to help you do this. So thanks very much for that. I know a lot has gone into this. What is it? Is it an app? Is it what are we calling it? What's
Rachel, I have exactly the same dilemma as well. I don't know. Is it
what
a
have you
web app?
produced?
Is it an interactive tool? Either of those is fine,
yeah,
I think,
yeah, an app might be too generic, and you might have to then immediately explain what it is and does. Maybe a tool, maybe a resource. I don't know that. Maybe you can ask all these people who are going to help you. Yeah. So there's a couple of questions that people have posed on Menti, but I was just I am sort of quite fascinated really about all things around the future population, health and care need, and so on and so forth. So I suppose, and you might have covered this. Now, this might have been me not concentrating at the beginning, Paul, and I do apologise. I was mucking about with something. So who actually is this for? You mentioning the public. Is this who is going to consume the information in here, and how is it intended for them to sort of use it?
Yeah, so I think that's a really good question. So I think what we've done with this is we've tried really hard not to kind of overcomplicate it or restrict it, such that kind of we're limiting the audience, only to people who, this where this might be part of their day job. I kind of really think that the nature of this sort of question is kind of fundamental to so many things that we might think about in healthcare, that it's probably of interest and use to a really wide range of people. So with this particular output, we think potentially there's a lot of people that might want to or gain benefit from interacting with it. We've kind of got ideas for kind of more focused outputs for kind of other groups, I guess. So one of the things we're thinking about is, do we want to perhaps produce an R package which would allow people who are kind of doing this sort of planning within ICSs, for example, to really get into the detail and to go through this exercise in detail for their local area. But kind of we think that would be a slightly different, more tailored output probably. And so yeah, there was one more. Yeah, go on. I'll leave it there. But yeah, so we think potentially the audience is quite wide, I guess, is kind of the short answer.
Okay, so it's not a tool for analysts in health and care settings to use, but it could kind of it might they could use it in conjunction with maybe more detailed local planning. It feels like it's something that could be used to help explain things in a different way to a wider audience.
Yeah, we want to engage people with this question. So we think particularly that this issue around health status is overlooked. We think it's important. We're not suggesting that kind of, in this kind of one project, we've somehow kind of solved it as an issue. But we think it definitely kind of warrants more interest, and kind of, hopefully we'll kind of pick up what other people are doing in this area, and kind of, the idea is over time, kind of we can kind of get to kind of some better or more improved methods for kind of how we handle this in these sorts of exercises. So yeah, it's kind of about engaging a wider audience in this sort of question, and kind of using that to build a bit of momentum around improving some of our methods in these areas, I guess.
And I haven't read all the little words because they're little on my screen. So some of this might be covered in sort of the explanations, which are a part of the tool, and it's called a tool within the tool. So that's what I'm calling it. Yeah. So we're kind of referring to healthcare. So, but we're probably also as relevant, just as relevant, more relevant as well to health and care. So this is as we look at the healthcare, the health status. You can't or one can't help but think about that broader picture of prevention and also services and support in a more of a care setting, and the influence and the impact it has on that as well. So I think it feels like it's the right thing to do to keep it clean, if you see what I mean. So you can have that sort of clarity of understanding of the the things that you've unpicked and drawing attention to and so on. But it's also that bigger bigger picture as well. So it's not just healthcare; it's sort of health and care, and then sort of there goes the dog.
Yeah. So I mean, one of the things I would say is that kind of the results of this sort of modeling don't necessarily show something that we should be aiming for. We're showing what today's service provision would look like for tomorrow's demographics. We're not saying that's desirable. And, if you think about kind of lots of kind of the direction of policy in terms of prevention, modifying demand or offering more community-based services, altering supply, then that would mean things would look different in the future. So the focus here is really around if service provision remains like as it is today, and our demographics change in this particular way that follows a particular scenario, then this is what the level of demand will be. But obviously, people might want to play in how they think service provision might change. But that's kind of another layer on top, I guess.
It is, and probably easier to do when at a local level, when people have a better understanding about their own sort of strategic planning and whatnot. So I've got a couple of questions that I think we've got time to pick up. We've got a comment in the chat. I don't know whether you can see that. So it's from Sarah Glover, who says, great presentation. Indeed it was. So in the last visual where you overlay model usage without taking into account health status, is it possible to provide a range of utilization estimates rather than a single point?
Okay, you can still see my screen, can't you? I
yes.
think.
Yes.
So let's quickly whiz down to so so when I'm clicking on here and you're getting the red dot, which is without an adjustment for health status, then then the uncertainty around that
Mm-hmm.
estimate is linked to solely to changes in population size and age structure. So that estimate would move if you selected a different ONS variant. So that's so there's kind of our treatment, and I'm kind of really aware of this, our treatment of uncertainty within how we present the results. There's kind of two different types going on. We've got the probabilistic treatment of uncertainty around health status, where we've used that um, distribution from the expert panel in a Monte Carlo process to generate the range of possible futures, which are kind of the shaded bars. And then separately, we've got a kind of more scenario-based treatment of uncertainty around how population size and age structure might change based on those ONS variants. So in an ideal world, it would be preferable for me, I think, if ONS were to produce um, some sort of probability-based um, assumptions around how population might change, but that's not how they operate at the moment. I
No.
don't know. Possibly they do that in some other countries, but not in ours. We kind of get these fixed variants. We've got 11 here, so the treatment is different, which to some extent is kind of complicates things somewhat. But you can see both of those separately, but it would be cleaner, I think, if we could somehow incorporate the uncertainty around population projections probabilistically. But until ONS produce the projections in that way, we don't really have that option unless we want to do something ourselves, which is probably it wouldn't be a insignificant task to take on, I don't think, and we're probably not best placed to lead that. So
Yeah. Okay. Thanks. Thanks very much for that. I've shared my screen. We've got one or
oh, yeah, I
two
can see that now,
minutes
yeah.
to go. So on my screen, which I'm not actually looking at myself, but I am now. There
Okay,
are a couple
yeah,
of
yeah.
there's a couple of questions based
Oh
on
yeah,
a
oh
couple.
yeah, very
So
good ones there. Yeah, yeah.
yeah. So
Okay,
so
yeah.
so you can pick the ones that you like the best and ignore the ones that you don't like because you literally have only got a couple of minutes. But just in advance of people running away, if people would like to ask you like further questions, A, they can email you because we're going to be sharing your email
Yeah, of course
address.
I
You've
can.
already
Yeah,
shared.
yeah.
And B, I'll invite you to respond to the points that are raised on here if we don't get a chance to go
Yep.
through them.
Okay.
So pick one or
I'll
two
try
and
and whiz through a couple in
yeah,
2 minutes
sure.
then. So
Okay.
the question around there's a couple there around ONS projections
Yeah.
and which one. So at the moment, these are the 2018 based subnational projections, which
Okay.
obviously is far, far from ideal.
Mm,
And someone's flagged up, um, the results of the census, and we are very aware that for certain geographies, certain parts of the country, the results of the census suggest quite different population levels than those suggested from kind of the projections, which were essentially rolled forward from the position in 2011.
yeah.
Um, our ability to correct for that is is somewhat limited until ONS produce a new set of projections, and they've
Yeah.
kind of really been procrastinating about this. The date for the next subnational projections has constantly been pushed back and back and back and
Mm,
back. So I think now the latest is it's spring 25.
no.
Um, I know it's not great.
Mm,
But obviously whenever those new projections do become available,
yeah.
we would look to drop them in and incorporate them into the model. And then
Yeah.
the other question is around, okay, well, I don't want to use ONS projections because, in our area, we've got our own kind of bespoke projections that, for example, might be housing led. So yeah, again, that's a really good question. And one of the one of kind of the potential developments for the tool that we've talked about is to have the ability for people to either drop in their own population projections, or to drop in data for their own service. So we've only kind of got the main acute points of delivery in here. But in theory, if people had age-specific utilization data for any service, that they could provide in a kind of a structured format, then potentially we could incorporate that within kind of this tool. Whether we do it within the tool itself or whether that would better sit inside kind of as an option within a kind of a separate standalone R package, then that's something we'd have to think about. But both of those, those are kind of really good questions and something we've kind of started to think about.
Okay. Well, we are. Thank you very much for that. I'm going to stop sharing. There's just one or two other questions or points raised on there, which we won't have time to go through now. People are hungry. Well,
Yes,
just change
sure.
your name. They're hungry. They're hungry. They're going to change your name. So thank you ever so much for going through that. I think people are sort of seeing that it feels like so much potential for it, both in terms of just a tool to really help explain and sort of draw attention to the in particular, like you say, to the health status and so on. But also the possibility of having more bespoke versions of this going forward as well. So I look forward to. I'll have a look at it, Paul. I'll see if I can break it. Promise.
Great, thank you, Rachel.
No problem. It'll be my pleasure. And I'm sure others will do too. So I'll follow up after today. And I haven't got time just to mention up and coming huddles, and there's one or two other things to mention, but these can wait till next time, everybody. And well, I'll thank you again, Paul. Thank you everybody for coming, and I'll see you again in approximately 2 weeks minus an hour.
Thanks all. Take care.
Okay. Bye bye.